Hello, ladies and gentlemen. Welcome to Has 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 25, Hypertensive to Healthy, Keeping Patients Safe with Remote Monitoring. It will be presented by Hai Simham, Professor of Obstetrics, Gynecology, and Reproductive Sciences, Division of Maternal Fetal Medicine at the University of Pittsburgh School of Medicine, Executive Vice Chair for Obstetrical Services at Magee Women's Hospital at the University of Pittsburgh Medical Center, and the Director of Clinical Innovation for the Women's Health Service Line. He will be joined by Beth Quinn, Director, Women's Health Operations, University of Pittsburgh Medical Center, Magee Women's Hospital, and University of Pittsburgh Medical Center Health Plan. Enjoy the session.
I'm pleased to have the opportunity to speak with you today about our program to use virtual care to manage a population of women in the pregnancy period and postpartum period, managing a variety of risk conditions and helping us manage our population in the Women's Health Service Line now in the setting of the COVID pandemic. During this presentation, we'll go through our key learning objectives, review the impact of hypertension during pregnancy and the postpartum period in terms of its relevance and significance, discuss the impact of COVID-19 in our women's health population, demonstrate how we've used data and analytics to identify and support meaningful and effective interventions, and talk about interim results of our ongoing program. We recognize that the benefits of a service line structure and interdisciplinary team approach to improve processes and outcomes are relevant across an episode of care, and we'll for sure make that point today. We'll discuss barriers to the optimal identification and management of postpartum hypertension and talk about how we've used innovative strategies to overcome common barriers that many care providers have in this setting. And finally, we'll demonstrate how clinical innovation can be effectively scaled for a specific population and episode of care. And we're going to use the use case of the Women's Health Service Line at UPMC. UPMC is a very large health system located primarily in Pennsylvania, but also with hospitals in Western Maryland and Western New York. It is a $21 billion world-renowned healthcare provider with almost 5,000 employed physicians and a broad geographic reach that spans urban and rural populations. So the scope and scale of UPMC is quite broad and makes our work generalizable across a variety of care settings. Within the Women's Health Service Line at UPMC, in an effort to champion clinical innovation and develop and disseminate programs of care to optimize excellence and improved clinical outcomes, we initiated a program called HATCH. This is an interdisciplinary group of expert providers and problem solvers. We have clinical and operational, finance, and data analytics team members who are core at developing processes, technologies, and payment strategies to deliver the best care to the right women at the right time. Our goals are to accelerate advances in virtual care, to optimize population health, and optimize patient engagement and the patient experience. We've had the great fortune to have outstanding executive leadership, sponsorship, and buy-in, and this initiative is sponsored by UPMC Magee Women's Hospital, University of Pittsburgh Physicians Department of Women's Health, and the Magee Women's Research Institute. This figure illustrates our general approach to the management of our population and how we use clinical innovation to essentially triage the care that's required for women. The bottom of the pyramid shows population management and central monitoring. And as one goes from the bottom towards the top of the pyramid, the degree of intervention, the degree of touch, if you will, increases, but the relevant population decreases in size. And so going from population management and central monitoring all the way to the top, which is inpatient face-to-face care for high acuity cases, we recognize that there's a series of strata or tiers of care, and we are fairly clear in trying to minimize the top of the pyramid for only instances where it's required by optimizing the use and distribution of those things below the top of the pyramid. The postpartum period has recently been called the fourth trimester. This is intended to follow from what we all recognize are the sort of typical 3 trimesters of pregnancy. And the relevance of the nomenclature fourth trimester is to call attention to the importance of the postpartum period for women in terms of risks to them and opportunities for intervention and the necessity of care. So hypertensive disorders during pregnancy complicate as much as 15% of pregnancies, quite common. It is among the leading causes of readmission postpartum and resource utilization. It continues to be an important reason that morbidity and mortality continues to rise in the United States, making pregnancy less safe now than it was 30 years ago in the US. Historically, postpartum follow-up visit has been a face-to-face visit with an obstetrician, gynecologist, or midwife occurring 4 to 6 weeks after delivery. The American College of Obstetricians and Gynecologists has proposed this new paradigm, this fourth trimester, in order to make sure that the right care is delivered for women across that first 4 to 6 weeks postpartum rather than just at the tail end of that interval. Hypertensive disorders of pregnancy are basically divided into 4 categories: chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and superimposed preeclampsia. The definitions are listed here under each sub-bullet. I won't go through the process of reading them all, but it is a complex series of conditions. In aggregate, the total of these complicates about 15% of pregnancies. And while we typically talk about the cure for preeclampsia being delivery, in fact, it is an important part of morbidity and risk across the immediate postpartum period, as well as in the life course thereafter, increasing the risk of cardiovascular disease for women across their entire lifespan. I'd like to take this time to point out that, of course, healthcare today is different indelibly than it was a year or 2 ago, and the COVID-19 pandemic has dramatically changed how we do so many things in the world, including the delivery of healthcare and the delivery of women's health services. It's important to recognize that virtual care is part of how we've managed patients in the setting of COVID-19 and will be part of how we manage patients moving forward beyond COVID-19. This is an illustration from an article in the New York Times about prenatal care. Prenatal care may look very different after coronavirus. The notion that pregnant women will seek engagement virtually and crave that kind of contact. Our approach to care delivery during COVID-19 using virtual care and our population health strategy has really focused on 3 areas: video visits, patient-centered care pathway, and remote monitoring. Video visits primarily for us have been live synchronous video visits for prenatal care. The intent is to reduce in-person visits and interdigitate face-to-face prenatal visits with live synchronous video visits during pregnancy, using an evidence-based schedule and structure to prenatal care. This approach to prenatal care has demonstrated high patient satisfaction, a reduce in pregnancy-related patient stress, and comparable metrics with respect to maternal and neonatal outcomes. For patient-centered care pathway, we focused on the immediate postpartum stay in the hospital after a woman delivers a baby. Traditionally, the approach has been time-based, day 1, day 2, day 3, with particular order sets that happen on each of those days. We've pivoted the approach to the postpartum care with a focus on milestones, that particular objectives can be achieved, and they can be achieved on the patient's pace in a patient-focused manner. And as it turns out, patient engagement and length of stay are improved when one takes this approach. It's designed to optimize the experience and, as a side benefit, reduce length of stay in the hospital. We've bridged care to the postpartum period by having nurse contact with follow-up phone calls after hospital discharge to identify problems with an experience or medical conditions where surveillance or care is needed. And finally, remote patient monitoring. We've focused on postpartum hypertension. The intent is to promote proactively the patient's engagement in her own care. She checks her own blood pressure, follows her symptoms, and is connected to us and stays engaged in her health condition, hypertension, in the postpartum period. The intent is to not only optimize that engagement and improve health outcomes, but reduce readmissions and optimize cost, to enhance care adherence, and to bridge care into the postpartum period by creating continuity of care. To date, with the advent of the COVID-19 pandemic and the big demand to reduce face-to-face care, we've conducted more than 1,800 video visits just in the first month, and thereafter have continued to do several hundred per month. More than 1,600 unique patients with at least one video visit within the first month of our program, and more than 200 providers across a broad range of training and experience and geography conducting these video visits.
I'm happy to have the pleasure to speak about the operational part of our program, as I have been leading this for the last several years. Eligible patients are enrolled in our remote monitoring program through the postpartum period. We can identify them by provider if they have a hypertensive diagnosis, if they have high blood pressures in the postpartum period after delivery, or if they were treated with magnesium sulfate as one of the medication choices during the postpartum period. Nurses are also able to enroll patients, as we have a nurse-driven protocol that has been developed. The report will go to a nurse in the morning to identify those patients based on those three categories. If they have not yet been enrolled in the program, they can discuss it with a provider or order it themselves. We also have patients that are enrolled through our ED at our hospital. If they present and have not been enrolled, but do not need to be readmitted, they can enroll them at that point as well. Patients will receive a text for the 14 days straight, 9 a.m. and 1 p.m. If they have not responded to the 9 a.m., they will be prompted on their phone by a text to answer a set of questions, enter their blood pressure, their heart rate, which is then sent to a call center. The nurses there are able to follow an algorithm and decide if the treatment should be to send the patient to the emergency department, to call one of our OB providers that is on call, or just to continue to manage them or outreach to them and call them. We have 4 OB doctors that are MFM providers that are our call group that we will respond to during 7 days a week for the program. The program will continue for 42 days. The first 2 weeks are continuous every day. Beyond that, the 3 days a week would be for the non-medicated patients, and then the patients that are on medications will get 5 days a week text messages sent for the next 4 weeks post the first 2 weeks. So it's a 42-day total program for them. We also look to ensure that we have primary care that is connected for the patient. So beyond the episode of pregnancy, beyond the 42 days, that they have then continued to follow up with either a cardiologist or a primary care physician. We will assist them with that as well. One of the things that was eliminated was the supply challenge during COVID. So prior to COVID and for our program, we were providing the blood pressure cuffs for our patients. There is a cost for this that is associated that we had some donated in the beginning, and then beyond that, our hospital and our service line agreed to purchase these cuffs for us. The blood pressure cuffs are not covered as a service for most insurers, but we know and we knew that there is the potential to identify all of our patients that have hypertension and high-risk conditions if we were to give them these cuffs. So COVID-19 came and we had the telehealth movement, so we were able to then purchase 6,000 blood pressure cuffs. We distributed those across Western Pennsylvania to all of our OB providers. Our patients, we were able to mail them to patients, deliver them to offices, so that all of our patients had cuffs during the prenatal period for their video visits, which also enabled us to increase our enrollment in this program because now patients had cuffs prenatally we didn't have to worry about providing them in the postpartum period. It makes it a lot easier. And along with the milestones that we were sending patients home a little earlier, it gives us the ability to enroll more patients in the program that we figure maybe were a little more low risk, but we wanted to make sure we were monitoring them. This has also allowed us to provide a lot of education to patients about the cuff, how to use the cuff, how to manage their own blood pressures, what's normal for them, what are signs and symptoms to look for, and when to call and report that to their providers. They're learning that during the pregnancy. They also know that in the postpartum period, whether they are enrolled in our program or not. This is a picture just to show you some of the text that would go to a patient. You do not need an app on your phone. This is something that is sent to them via text with Wi-Fi connectability. They would just get a message that said, "Welcome to the UPMC remote monitoring program." Click the text and we will show you the next screen. It is personalized for our UPMC. In the beginning, they have to sign an end user agreement by just saying that yes, they do want to participate. They would like to enter their birthday so that they verify who that is. This shows 1940. If that was the actual date, they would not be enrolled in the postpartum period. They would not be childbearing. But this is what this would look like. And then it says, thank you for participating. You will receive your next message tomorrow. We do have videos that are embedded in our program as well at the beginning, the middle, and the end, filmed by Dr. Simhan to talk about the importance of the condition, the importance of the follow-up, and the importance of continuing with the program. Also thanking them and providing them with some basic education about their condition. Here's a brief video about our program that we'd like to share with you.
Welcome to UPMC's remote monitoring program for postpartum hypertension. I'm Dr. Hai Simhan. I'm a maternal fetal medicine doctor here at McGee Women's Hospital of UPMC. Hypertension in pregnancy is a really important condition, and you've just delivered a baby and have high blood pressure. It's important for us to work with you to manage your blood pressure and your symptoms to make sure that you do well in this postpartum period. Many women with high blood pressure after delivery continue with high blood pressure for several weeks postpartum, and it'll be important to follow those blood pressures to make sure that you're safe, and if you need medications, to put you on the right medications that control your blood pressure well and keep you healthy and safe. Also, many women with high blood pressure during pregnancy go on to develop hypertension years later, and so it'll be important to connect you with a primary care provider, internal medicine doctor, or cardiologist to manage your blood pressure issues as your life continues beyond this pregnancy and postpartum period. We look forward to working with you to manage your blood pressures and your medications if you need them for the 6 weeks that follow pregnancy. We'll be in touch with you several times per week to do so, and want to use this to connect you with your provider in a convenient way. Remember that this program is not for emergencies, and so if you do have an emergent condition and a problem that needs to be addressed immediately, please contact your obstetrical provider directly. Thank you.
The remote monitoring every day, the text would then, when they click in, ask them this series of questions. So we base these questions, we wanted to only have a few, make it simple for patients so they feel engaged, yet not burdened by the questions. So it's just asking them how they're feeling today compared to before that. Have they been to a provider or had any medication changes since the last time they entered their texts? The reason for this is because the nursing call center does not have the ability to go into the electronic health record every day to check every patient to see if anything happened since the last time they entered, especially if it's a patient that hadn't entered for a few days. So this will alert us to the fact that something has changed for them. We also get the blood pressure, the heart rate, and we ask conditions that would alert us to that's something that the patient needed immediate treatment for. We have them as medium risk or high risk on how fast the call center nurses will respond to them. And then we have an entire algorithm that's developed for us to know how to manage the patient. Last year, we published an article on some of our initial findings. So based on 409 patients, this is some of the characteristics that they had, broken down by race, age, prime, or multiples, and also shows that, as Dr. Simhan had alluded to earlier, severe maternal morbidity is higher in our enrolled patients, 7.4% compared to the non-enrolled. So we know that from our data, these patients are sicker. They usually deliver preterm, And we were able to break down all of our data. We have a clinical analytics dashboard that was able to look at all of the factors, and we're able to start really studying as we look at everything that comes in and all the data that flows in from our patients. This is just a picture to show you some of our data and our geographic spans, as we alluded to earlier as well, about how large our system is and across Western Pennsylvania. The arrows, the blue arrow in the red box shows Allegheny County and Pittsburgh, and that's where McGee is, and that is where most of our patients are enrolled and are out of. However, the other two blue arrows are where we have spread our program to two smaller rural hospitals in our system. So UPMC Northwest and UPMC Horizon are also able to enroll patients, still managed by our same central team. The yellow arrows up in Erie and then out in Altoona will show you exactly where we would like to go. Those are our two next hospitals that we will go to. And this just kind of gives you an array of the footprint that we have across the state and how many patients we are able to manage and the large geographic spans. The importance of remote monitoring being that you don't have to be where the hospital is for us to manage, and you don't have to be in such a small area as well. One of the other goals that we had was to make sure we bridge the care from patients for the episode of pregnancy to postpartum. So to do that, we had one of our own providers start a clinic within our hospital called the Bridges Postpartum Hypertension Clinic. This is just some information that's provided to the patients. It's sent electronically along with a video during the program so that we're able to enroll them there. If they do not have a primary care physician that's identified, this will help them also see a cardiologist and a specialist for this so that we can help them to identify their long-term care plans beyond the episode of pregnancy and preconception before they decide to have another child as well. Some of the results and the outcomes, which have been really wonderful from our program, the one that I don't have listed is how many patients we have enrolled in the program since we started. We have enrolled approximately 2,500 to 2,600 patients. We have ordered on getting closer, and we're edging up to 3,000, I think, as I looked last week. So out of those patients, 92% have had initial patient engagement. We have a large amount of patients that when we enroll them and explain the program, do engage and actually stay part of the program. 72% will remain for the next 4 weeks, 28 days, which is usually when they are going back to see their OB provider. And if they are not on medications and are feeling okay, sometimes the provider will stop them then. They don't always continue to the 42 days, but several do. Patient satisfaction is very high with the program. We measure this by a midpoint, and a post satisfaction survey that goes along with the texting, and we ask how they like the program, what they think about their diagnosis, do they understand it, do they know their medications. All those things are asked of the patient. We have very high satisfaction for it. Medication management, 38% of our patients are discharged home on medication from the postpartum period in the hospital. 62% are not and go home on non-medicated pathways. During the program, we have about 29, and this ranges sometimes in the high 20s to the low 30s of how many of our patients that have been discharged on our program that we will then medically manage. This means that we initiate medications on them, we change our medications, we increase, decrease, or we can titrate them off of medications during that period when they were with us. Here's a brief video about our program that we'd like to share with you.
He's a mommy's boy.
Skylar Andrews was in perfect health when she became pregnant with her son Zane, but toward the end of her pregnancy, Skylar's blood pressure skyrocketed.
About 200 over 114.
Skylar had a condition called preeclampsia, dangerous for mom during pregnancy and after.
It increases the risk of heart attack and stroke over the lifetime about 2.5-fold.
Please ensure that the cuff is at the same level as your heart.
That's why doctors encouraged Skylar to check herself at home with this portable cuff and a smartphone. She could. 38-year-old Jessica Wolf also needed high-tech support. After years of battling infertility, this was a big surprise.
We still struggle with, like, wow, this is actually happening. This is really real. We're gonna have a baby.
Jessica is considered higher risk. She has gestational diabetes.
So yeah, they come in at 7 and 9 and 1 and 3 and 7.
An app on Jessica's smartphone generates reminders to check her blood sugar 4 times a day and report back so doctors can respond.
We want to be able to identify the patients who need a phone call and not just identify them when they show up in the emergency department.
Your systolic pressure is 121.
Skylar's blood pressure is now back to normal. 2 conditions made a little more manageable with the touch of a button. I'm Marty Salt reporting.
85% of our patients have a follow-up appointment, which is a really huge goal for us to make sure that these patients are following up with their obstetrician in that 4 to 6 week period, or at least sometime in the 6 week period in the postpartum. So this is a huge goal, and this was a large improvement over a national benchmark, which is usually about 60% nationwide for patients to follow up in the postpartum period. About 12% of our patients have at least one ED visit, and most of that is because we send them there usually. If they are having high blood pressures and are symptomatic, they usually need to go to the hospital to be treated. 8% of our non-enrolled patients have at least one ED visit as well. So a lot of times patients will still come into the ED in the postpartum period. If it is for hypertension, they are usually enrolled then after. And prior to the program, when we looked at our data, about 10% of our patients initially were following up with a primary care physician. Since the program, and since we have put a lot of things in place, including the Bridges Clinic and a lot of referrals to other primary care physicians, we have had that go up to at least 24%. So we have gone 2.5 times from where we started of patients that are following up with a primary care physician beyond the episode of pregnancy, knowing that that is something that is important for their long-term health.
One of our key metrics that we aimed to improve with this postpartum hypertension monitoring program is the rate of readmissions. This run chart shows the frequency of readmissions labeled on the y-axis and time of the program on the x-axis. And prior to program initiation, we saw readmission rates generally in excess of 1%. With initiation of the program in March of 2018, we saw a decrease in the frequency of hospital readmission. One of the important points of data analysis and ongoing surveillance of the program is to make sure we can steward the program appropriately and maintain results. We did see an increase in readmissions thereafter beginning in mid-2019. We found that a substantial proportion of the readmissions occurred over the weekend, where patients would have elevation of blood pressures and symptoms, but we were not available to answer their questions either from the call center perspective or the program physicians. And so as a result of seeing this pattern, we initiated 7 days per week coverage of the program and saw a subsequent decrement again in the readmission rate. And that readmission rate has been sustained as a decrease today. With respect to important financial outcomes of the program, patients enrolled in the remote monitoring program have less costly episodes of care. Women enrolled in this program have fewer emergency department visits and fewer inpatient admissions than women who are not enrolled in the program with hypertensive disorders of pregnancy. There are several notable differences in cost among patients enrolled in our program. On average, costs per patient are $400 lower for patients with emergency department visits or inpatient admissions, and $100 lower for patients without ED visits or inpatient admissions. So across the board, the program has yielded financial savings for our service line as a result of reducing costs associated with ED visits and inpatient admissions. With respect to our patient-centered care pathway, the program focused on a milestone-based approach to the postpartum stay as opposed to a time-based approach to the postpartum stay. We found an average of an 8-hour reduction in the average length of stay in the postpartum period for women who have a vaginal delivery, and an average of a 10-hour reduction in length of stay for women who have a cesarean delivery. There have been no notable increases in readmissions or emergency department visits for mom or baby. This is an important balance metric for us. We wanted to make sure that in shortening length of stay, we didn't inadvertently increase the need for care outside of the inpatient episode of care, and in fact, we have not done so. And with respect to the patient experience, 90th percentile HCAHPS patient satisfaction rating to date with respect to the program since we've initiated the patient-centered care pathway. Overall, in terms of summary of key learnings and recommendations from our virtual care experience in the Women's Health Service Line, orientation, education, and enrollment is crucial for successful patient engagement. This is true with providers, staff, as well as patients. Establishing expectations and integrating these care elements into clinical care is essential for sustained programmatic success. Second, identifying eligible patients is key, making this as automated as possible with strategies like the automated hypertension report that goes to the units, but also creating a sense among providers and staff that these programs are part of essential care, and providers and staff can refer patients as well. And so it acculturates the program into the clinical care plan. Third, it's critical to have a core team of nursing and providers to manage the patient. With respect to our postpartum hypertension program, while patients may have a wide range, 200 plus obstetrical providers, the core of the monitoring program has a team of focused call center nurses and a team of 4 maternal fetal medicine providers who are on call for that program. They provide a centralized structure to the program and maintain diligent pathway adherence. And finally, we've noted that strategies like our remote monitoring program have maximized the amount of time that patients stay engaged with us. Our intent for that specific program is to reduce readmissions and reduce morbidity and optimize the transition to care. And this general approach can hold true, we think, for a number of use cases in the Women's Health Service Line, in pregnancy and the postpartum period. We'd like to thank you for your time and attention, and both Beth and I are willing to answer questions and look forward to ongoing discussions in this domain. Thank you.